talked earlier about going in and exposing impacted teeth. That may very well be something an oral surgeon, you would work in tandem with an oral surgeon for the surgery.
What would a craniofacial fellow do beyond oral surgery?
From a dental standpoint, like you know, we have a craniofacial fellowship here. Yeah, you would ask that. So beyond oral surgery, like these, the craniofacial fellow, without going to the program's description, would be that person who may very well be kind of be quarterbacking for the children with craniofacial anomalies. So they might have a child with Treacher Collins, they might have a child with bilateral cleft lip and palate, and they might serve on a craniofacial team to help that. So typically, my experience with a craniofacial fellow has come from the orthodontic standpoint, where they are coordinating that care and then trying to figure out how to utilize other specialties or dentistry to help this child have a more functional dentition. So whether that is, they might have mid-face hypoplasia, so their ear is sunken in, so their maxilla might be further back, and they have a either normal developing mandible, and their mandible is very forward, so it's, okay, they might not be the one who's performing the surgery, but this is our end goal that we can get for this child, and it's working with, if they needed to harvest bone graft, that stuff like that, getting the teams together so that they can go about getting this kid the surgery to to advance the maxilla, or retrude the mandible. You know, it might be a combination of the two to get them into a more harmonious relationship. Yep. Okay. Yes.
Just a general question. So if pediatric dentistry is inclusive of all these different services and specialties, what's the distinction between services you can offer and sending them off to somebody who's not well versed in pediatrics? So sending them to an oral surgeon rather than, or sending them to a periodontist rather than.
Okay, start the sentence again.
So, you were explaining that pediatric dentistry includes aspects of all these different specialties.
Mm-hmm.
So what's the distinction between services that you can provide versus knowing when to send them off to specialists?
I think it's that last part is, as a specialist, knowing or avoiding getting myself past the point of no return. So what do I feel comfortable doing? What do I know I need to send to a specialist? And then it's about then having that network of folks. Not every oral surgeon is cool with seeing kids. Can they do the work? Yes. Will they? No. So as a specialist, I've got my work cut out for me when I go to open, is to identify other specialists that I may very well need. I mean, I'm not going to be cutting open gums and doing flap surgery on a child with localized juvenile periodontitis. So, it's going to be comfort, experience, and willingness. So there's certain things I'm willing to do, certain things I'm not. All right, I'm not going to cut into the palate after I've taken and interpreted a cone beam CT. I'm not going to cut into the palate, go and find that canine that's probably up here by the kid's nose and expose it, put the wire mesh on there, affix it. That's just, no. But are there programs out there that maybe had a whole lot of ortho oral surgery aspects and folks might be comfortable doing that? Maybe. You know, maybe those folks who might have done a GPR and feel a lot more comfortable doing surgical extractions, and then they've gone and done pedo, they might be able to do that. Folks who might have done a GPR, I got a colleague who's pedo, but he did a GPR before he did his pedo. Then when I was dental director at another community health center, and we were down a dentist, and he needed to do something while his insurance credentialing was taking place somewhere else, I brought him in. He hadn't declared his specialty yet, so I brought him in. He was still a pedo doc, so he could still see pedo by training. He could still see my kids when I wasn't there. I didn't work 5 days a week there. And then, but he would also do molar root canals. I mean, what health center is doing molar endo? Well, you got somebody who's comfortable doing molar endo, he's doing molar endo. He's doing multi-rooted endo, so he's doing bicuspids. He felt comfortable doing, endo, putting stainless steel crowns on permanent teeth. Like, he was surgical extractions. He was going after root canal treated molars that had broken down, and he's getting in there, cutting things out and doing what he's got to do. And those would all be things I would have punted to an oral surgeon in a heartbeat. Or if I saw them in a kid, I would have punted to a GP, something along those lines. I would have, that's not where I felt comfortable treating. But there's nothing in a book that says pedo can do this much perio, can do this much endo. So I think someone who might have done advanced trainings in general dentistry might feel more comfortable doing root canal treatment with gutta percha and all of that jazz and permanent teeth than I would having come straight out of dental school right into pedo residency with not a lot of permanent teeth root canal therapy. All right? Does that answer? No, you don't look like it. I didn't answer, Julie. Say what you know.
No, that does make sense. I guess I'm curious about what extra training pediatric dentists get that general dentists don't.
Exposure to kids.
Besides,
Oh,
like,
yeah, it's besides exposure to kids. So you have a more labor intensive, your residency program is dedicated to children,
Okay.
individuals with special healthcare needs. Here we do ortho, so we are working and we're doing orthodontic cases, whether it's phase 1 or phase 2 orthodontic treatment. Some of your orthodontic treatment might require you to have, take it one step further and get with the oral surgeon, so you get to work all of that. There are other programs that when you go to interview or when you're researching or asking other folks who are coming out of those programs, what are their experiences? Every program is different. Some might be just straight more hospital and seminar based, whereas here we do have formal didactic stuffs. So we're in the classroom with our advanced didactic, advanced head and neck, immunology and microbiology, something about the stomatic, what I don't know. Another class, and that stuff. Like we go through an ortho boot camp with the orthodontic residents when we all are starting residency, actually before residency starts, and then we're doing our ortho cases. Our cases are not as complex as theirs. Their program's longer, and that's their specialty. But my thing I wanted to garner out of my ortho was enough information. If I wanted to do phase 1 treatment, I would incorporate that into my practice. If I didn't, then I wanted to know when was the appropriate time for me to make a referral to an orthodontist. Okay?
I suppose the question maybe is when we say, okay, this is a specialty we're going to have, there's enough about this particular area, one of the 9 that's unique. What is especially unique about pediatric dentition, or especially unique about the pediatric patient, so much that we're going to dedicate specialists to this field? And what expertise do those individuals specifically have that other dental specialties do not have in the training of this specifically unique population that we've said requires their own specialist?
That was a question. It sounded like you were answering a
No,
question. I won't have you say it again. But I think for the same reasons why in 1900 there were no kids that were being treated in the office, and in 1920 something that 15 schools weren't doing any clinical, 22 schools weren't doing any didactic. So you've got this population of kids, which when you're treating adults, they're coming with this sort of presentation from a preventive standpoint. How could we have modified their adult presentations with earlier and earlier intervention in their dental care. So you've got from an establishment and connection with the AAP, it's what do these kids need? What are we seeing? From prevention, if we've got adults who, smoking aside, other sorts of medically affected or medicinally affected clinical presentations they show, you know, what are adults experiencing? Okay, severe anxiety. They might have a fear because maybe they only come to the dentist when their face is swollen and they're in excruciating pain. So then they start to associate the dentist as a negative place. Well, what can we do? Okay, everybody come in every 6 months and be seen. Okay, but maybe I'm an adult and insurance is hard and I can't do this. And okay, so how do we get folks used to going to the dentist? And then more state, federal funds become available. And now we have insurance programs that are targeted for younger populations. Well, who's going to treat these younger populations? These kids they might have oppositional defiance disorder. You have kids who might have autism. You have kids who might have severe anxiety or acute situational anxiety. And they're a fear of needles. So do you just sit up here and let these kids and all of their fear, which is inherent of growth and development of a kid, just persist until they become that adult and then, oh gosh, my tooth hurts? Or can we modify this generation of individuals and we provide them with the tools that they need to get comprehensive care from an oral and systemic standpoint, and we increase insurance programs, insurance accessibility for these these youngsters to be able to see the dentist, get this preventive information. If you guys are out there in Alabama, these folks are grown and they don't know about a toothbrush, let's back it on up like a U-Haul truck and figure out what we can do to get these kids used to this environment. So it's still that process of recall. You experience it, you remember it, and tucks it away until you're back 6 months later, and then you see, oh, now I know how to do this is this. Oh, this is the cool camera she's going to use. That sort of stuff that really allows for this frequency to become second nature. You see what I'm saying? And if I was a kid and every 6 months I went to the dentist, then it's more like when I'm an adult, it's let me make sure I get myself into a situation that allows me to continue seeing the dentist every 6 months and hopefully not fall into the circumstance when we're there without, and then all HE double hockey sticks breaks loose. And then now they don't know what to do. They can't afford it, and they're looking for stuff, or you've got folks who are succumbing from dental infection that spreads systemically.
So pediatric dentistry exists not necessarily because the teeth are so different, but because the patients are so different.
I would say so. I think it's both. There are certain things that you would do on a primary tooth that you wouldn't do on a permanent tooth. There are space-saving things you would want to do on a because that's what they get first. And if we just took out every tooth that was not savable and didn't make any effort to try to save a primary tooth, so that might be, so taking it from a business standpoint, to do something when it's covered by insurance now versus the $5,000 or $6,000 worth of orthodontic treatment that's needed when they're older to try to regain space and bring in impacted teeth and try to make a way where there might not have been a way for teeth to come in, then I'd probably I'd err on the side of proactivism. I'd do it earlier than I'd try to do what I can to prevent those negative outcomes now. So there's that aspect. I think it's twofold. And it's a child who's a minor and cannot make decisions for him or herself. So then it becomes an education piece. So now it's maybe you're taking into account parent, guardian, and their experiences to really try to shape a familial habit and try to break those chains of putting your 2-year-old to bed with a bottle of Kool-Aid, or putting your crying 3-year-old to bed with Mountain Dew, and then wonder why when they come to the dentist when they're 5 that 15 teeth have to be extracted. So it's those sorts of things that allows us as specialists to hone in our skills and focus on this population. I like to think sometimes now, while hog tying a child, placing them in a protective stabilization device is a thing. There oftentimes, but that does require consent. So you might have folks who don't agree to that, and now you might have a kid who's becoming anxious, is getting squiggly. So I could see someone who is not well versed in pediatric dentistry aborting treatment and sending to a specialist. Whereas I'm now this kid's end of the rope. Like I'm not gonna say, I can't do this, go to another pediatric dentist. It's now on me to take care of this child's needs. And then so I might be, doing some dentistry, prepping a tooth while the kid's doing a little bit of this, and I need to keep them safe. And so it's like rodeo dentistry at times. And not everyone feels comfortable with that. And it does take, I will say, those 2 years of training to be comfortable with that, to be able to do a good job well and quickly. Y'all gonna have 2 hours, don't forget your thought, because I'm gonna forget mine. You're gonna have 2 hours to see one patient in the real world when y'all are in clinic, okay? In real life, one, you can't make any money seeing 3 patients a day, just in case you didn't think, unless all of your cases were full mouth rehab and you're doing 10, 12 crowns every day, all of those sessions. But so with pediatric dentistry, the fact that a lot of my kids, probably over 90% of my kids, probably closer to 95, have state-funded insurance plans, not to say that I can't make money off of it, but then it becomes more volume-based. So I can't, unless I needed to, spend an hour to do 1 or 2 teeth. You see what I'm saying? So then it's about doing a good job well, quickly. All right? Any other questions? So, yes.
Yeah, so in this program, do you guys do the kitty cocktails? The sedation, oral sedation?
Mm-hmm.
Okay.
At the hospital, yes.
And it's, okay. So
At
you
the
don't-
hospital, so you won't do
You don't
sedation
just do
here.
it here.
Mhm.
Okay.
And I don't know if, when you guys go and do your hospital rotation, so typically sedations are done on Mondays. And I don't know, because I thought pedo and oral surgery split each other. At least that might have been the case when I was there. So you might have been with oral surgery, or I don't know if students will rotate on the days that there are sedations taking place. But when you guys are on break, hospitals don't close. So when there's 2 weeks or however many weeks off in December you get, if pediatric dentistry is what you're interested in, I'd certainly recommend staying in touch with me or Dr. Ferretti or Dr. Ferretti. Y'all know that'll make sense at some point in time. And or Dr. Hema, and getting some clinical experience. Well, I won't be there. I'll be at the Rainbow Center, a different sort of environment. Are we cool with this thread of thought? Yes.
Our kind of tangential. Can FDOS prep kids?
Can FDOS prep?
Yeah.
No. They can fill, they restore. So expanded functions dental auxiliary cannot prep, they can restore.
Okay, but with kids,
Hmm?
can they work with kids?
Yeah.
Or is it only general?
So they can work with it. If there's a tooth to restore and they were hired to restore, they can restore. All right? I would, as a dentist, want to make sure that I'm getting post-op radiographs as a new hire, making sure that they're doing as good of a job or the bomb doctor better than me. If that's all you go and do, then there's that. All right. Be even bonus if they were a hygienist who can anesthetize. I've seen people utilize their hygienists in that standpoint, especially in a busy pedo practice. They could be getting your patients numb, move on. They can get them numb, maybe while you're prepping, and then y'all flip flop. So then they've anesthetized. Maybe I'm checking my email. Just kidding. Maybe I'm doing a hygiene check. They've anesthetized. I go in and prep while they're anesthetizing the next one. I move on. They're going to fill while I'm prepping. They come here. I check it until we're really cool. All right. I check it, and then we just keep things moving. All right, is a way to utilize an FDO. But if I can do a class 2 in 10 minutes and he or she can't, then we're either going to work to get you to that, or I might utilize you for sealants and class 1 restorations.
What would you say would be the average amount of time you spend per patient?
Appointments, amount of time I spend with the patient,
Yeah,
me.
you.
Me, okay. I walk around, hey, I'm Dr. Carey, and so we're talking from then. All right, because usually I work at a corporate office now, and I don't know anybody, right? So usually my patients are new to me. Very few times am I getting comprehensive care. So, maybe my total contact time with the kid is 20 minutes. In an hour, depending on what I'm doing. One quad, 20 minutes. Hour-long appointment. But at this health center, at the corporate office, I might have 2 columns of restorative with a patient arriving every hour, and then we have 6 columns of hygiene. So I might get in, get this kid numb, go do about 3-4 hygiene checks, come back, drill, fill, check it, get on. Or if hygiene's slow, if I check hygiene before I walk in the room, then I'm gonna get them numb, and then I tend to go right into my treatment, depending on what it is. All right, but that's a whole another. Maybe there's like a pearls, and y'all's ASDA rep wants me to come back and we can talk about how do you survive and little cheap things from Dr. Carey to save for a rainy day sort of thing, and we can talk about some of my other little techniques. Good? Okay, I'm bringing this back. Prosto. We talked about one because hers flew into the sky. So flippers, tooth replacement sort of stuff. All right. Anybody think of anything else? So you don't have to send to a prosthodontist for that. Pediatric dentists should feel comfortable providing that service.
Splints?
I'm sorry.
Splints?
Splints.
Like if a tooth was evulsed and then was put back in, maybe it's not stable, so you like splint?
Yes. Remind me of your name.
Ashley?
So yes, splinting teeth could be a thing, should be a thing if you've got an avulsed tooth. Absolutely, yes.
Would that fall under prost, or would that fall under more ortho in that case where you're stabilizing the periodontal ligament to let it reattach?
Or,
Okay.
I'm thinking of one, I'm trying to think outside the box. Trying to think about pedo stuff that might be pertinent. What?
Stainless steel crowns on pulpotomy too.
Huh. I would see that more as general. I wouldn't send a stainless steel crown to a prostate. Because they probably don't want to work with a kid anyway. They're probably wanting full mouth crowns and all of that jazz. But that doesn't mean that it's not applicable. Crown and bridge, I get where you're going. Prosto, you might have that teenager who is anterior tooth. They had a trauma. You were just temporizing, giving them something cute to get through their adolescence. Now they're done growing. Now we want to get them a zirconia crown. Maybe they've been traumatized, root canal treated. Root canal's been looking great all these years. It's stable. Maybe it's time to reinforce that with a full coverage restoration. So maybe that could be prosto, or you send it to a GP who does those sorts of EMAX crowns, all of that jazz. All right, but it's an aspect of prosthodontics is how it applies to pediatric dentistry. Anybody? We've talked about cleft lip and palate, yeah? I'm more concerned about cleft palate. How do you think an aspect of prosthodontics would play a role in this? Yes.
About like the making of like obturators and stuff.
Look at this girl. What's your name?
Becky.
Becky. Yes, making an obturator. If you've got a big opening between the nose and the mouth, and you're trying to feed a newborn, you probably might want to close off that opening. So this is an aspect, creating an obturator is an aspect of prosthodontics that pediatric dentistry may utilize. Yes.
I've also seen obturators. I met like a couple of like low like teens that had like benign tumors, and then they were like had like the big hole and everything.
Yep, I can see that. Absolutely. So we want to block off communication with other parts of the body. Try to keep the mouth within the mouth. Here, they tend to use what's called a PNAM appliance. It's a pre-surgical nasal alveolar molding appliance. So it's a step further. It combines an obturator with like 2 little antennas that are meant to help stretch the soft tissue, the lip, so that once they go to do the surgery, it's not, the sutures are not when they're closing the cleft lip, if there is one, which anyway, then it's not under tension, that there's enough tissue that has been there to close that space. All right, with minimal scarring. Any other way? Okay. Radiology. Well, we're reading radiographs all day, but does a tumor show up on an x-ray? Can a tumor show up on an x-ray? Yes. So that'd be something you may very well piggyback with an oral radiologist, oral pathologist on to identify those. Maybe you're not the one who's doing the biopsy, so you might tag team with an oral surgeon to perform the biopsy to get a definitive diagnosis. Anything else? Does cancer change the way your bone looks, depending, can it? Yes. So you might not see the lesion itself, but you might be able to see bony changes that show up on the radiograph first. Has anyone ever heard of sickle cell anemia? Okay, so I'm from a sickle cell family. My brother has the disease. The rest of us have the trait. Sickle cell will manifest itself on like a radiograph, and the bony trabeculae looks like a stepladder. So that's its hallmark thing. So when you guys go to take oral path and all of that stuff, they'll talk about the stepladder appearance of the trabeculae. So it looks like a stepladder in between the teeth. And we'll take it even just one step further. If you've got bone that's not necessarily as dense as 100% healthy bone, are teeth going to move quicker with orthodontic treatment, or they be the same or longer?
Quicker, right?
Be quicker. All right, bone's not as dense, so that's among all of the complex things with sickle cell anemia, which September is Sickle Cell Awareness Month, so that came right on time. It's a smidgen of goodness that might come out of it, that orthodontic treatment might not take as long for those youngsters. All right. Pathology, we just kind of talked about that. So you can see your tumors. You might be tag teaming with an oral pathologist. You might have soft tissue things, fibromas that are on the mucosa or on the tongue. Papillomas that are on the tongue, like little warty projections coming off of the tongue. Those things will need to be excised and sent for pathological evaluation and determination. If you've got a tooth that's been severely decayed, and you might just have a bite wing, and maybe the tooth is, the patient's complaining of a lot of pain and discomfort, taking that periapical might lead you to other imaging that leads you down a certain diagnostic pathway as to whether or not the tooth is eligible for a root canal treatment, or if it's not salvageable, non-restorable, needs to be removed. All right, aspects of dental public health. Sealants, yes.
Water fluoridation.
Water fluoridation,
Education.
education,
Access to care.
access to care. How so?
Like with dental HIPSAs, like being able to try to spread access into those areas or provide that.
So HIPSA is a health profession shortage area. So things like the National Health Service Corps, which is a scholarship that I had in school, is designed to do, is to put providers, medical, dental, to put healthcare providers in areas where there's a shortage of them and an increased need. I've got two more that I'm thinking of, and if you guys get them, we'll go to the next slide. I'll give you a big old hint. Smoking cessation. That sort of stuff, tobacco use, chewing tobacco, things along those lines. And then one more.
Data collection.
Data collection.
Sent to surveillance groups.
Absolutely. Data collection, surveillance groups, yep.
Biology.
Nutrition, huge.
Behavior risk assessment.
Risk assessments, I kind of heard that. Is there any link between pregnancy and oral health? Can children get pregnant? Are children who are pregnant at increased risk for complications and infant mortality? Well, they're not gonna be. Their child is at it is increased risk of infant right, so there's back to this educational aspect of it, but teen pregnancy, that sort of thing, reproductive health is certainly an aspect of dental public health that is relevant and something that a pediatric dentist would think of. Not every kid can be treated in the office. Whether it is severe medically compromised conditions, heart conditions, intellectual disabilities, mental just unable to cooperate or tolerate in-office treatment. They might have severe asthma and they're not a candidate for an in-office oral sedation sort of thing. These individuals may very well require treatment in the hospital setting where they're completely asleep under general anesthesia and all of their dental work is completed, whether that's from radiographs, through extractions, through if you're comboing the case with oral surgery or root or endodontics, maybe they're coming in and taking care of some salvageable teeth in this coordinated effort. As an endodontist, they can do a root canal more thoroughly and probably much better because that's what they do. So you team up with those individuals and you provide these patients this comprehensive care. All right, you might have folks who come miles and miles and miles away because there's an access to care issue. There's nobody in their area. So are you going to subject this family, and it's not solely because of that, but limited access to care is certainly an clinical need. So if you've got a kid who's got 3-4 quadrants worth of work that needs to be done, maybe they're small, these folks might come from an hour and a half, 2 hours away to see you. Am I gonna make them travel 4 hours round trip plus an hour or so for the appointment 4 times to get all of this work done? Yes, if they want to. If I have hospital privileges somewhere, I'm going to offer them that opportunity to have that care completed in one fell swoop while the child's completely asleep, get it all done, and then holler if you need me, all right? So there's times where kids who, we've done combo cases on children who have cleft lip and palate and getting their surgeries done. They've gone and the palatal expansion has taken place and plastics needed us to come in and extract the teeth. Or after the procedure, like they need us to remove the orthodontic appliance. Because kind of like you break it, you buy it. So they'd rather have the dental person come in, remove it. They do their thing. Maybe I'm extracting a supernumerary tooth that is in the cleft. And then I'm doing my thing. They're pulling graft from the hip bone, wherever they're doing. They're grafting their material. They're grafting the cleft. They're doing whatever they've got to do to close everything on it. They need me back at the end of the procedure to cement the appliance. All right. So those are aspects of hospital surgery. Maybe you've got a kid who's also getting ear tubes. You can tag team with ENT. You know, mom, your kid has a whole lot going on. Oh, they're also getting ear tubes done. Oh, okay, well, this might be something. Let's communicate with the ENT so they can come in, do their ear tubes, and then we just dirty up the scene with all of our dental stuff after the fact. All right? So, as we've learned, pediatric dentistry is so much more than just baby teeth. It's a commitment to promoting the prevention of oral health education. We're treating all sorts of dental infections or infections of odontogenic origin. We're recognizing and addressing craniofacial needs. We're aiming to alleviate pain and dysfunction with an expectation to restore form and function as best as we can so that we can improve the overall quality of life of these youngsters and hopefully shape what their familial approach is to oral health care. It takes a community to raise a child. It's an African proverb, and oral health is certainly important to overall health. If you guys haven't heard it yet, then you will certainly hear it throughout all of this. We practice dental medicine. The things that you're working on, these teeth that you're so making sure that you are doing your class 2 prep and you're not mangling the adjacent tooth, all of that stuff. That tooth that you're working on is attached to a living, breathing, organ functioning individual. Things that you do to their oral cavity can affect the systemic aspect of the child, same way that their medical conditions can have oral manifestations, which is our area of expertise. So from conception through birth, through childhood, adolescence, and adulthood, it needs to be a concerted effort between medical and dental communities as well as public health initiatives to really try to play a role in enhancing this overall health of children. So from all of the things we talked about, from trauma, from prevention, and water fluoridation, and sealants, and fixing cavities when they're small, to if they're big, what are we going to do about it? Are we going to be able to treat them in the office? Do we have to refer them to a specialist? And that's okay if you do. Just make sure you've got your resources in place. Is ultimately the reason I went into pediatric dentistry was so that I could be a part of these youngsters growing up to being adults who are not strangers to go, are not affected negatively about seeking dental care. When I was a 3rd and 4th year student, I might be young. Okay, there was a show called The Swan. Does anyone remember that? No, I'm old. Okay, so the show The Swan is all these women, it's primarily who they were targeting. You come in and you get all of this work done. They do your hair, the makeup, eyes, do your wardrobe. And it's like everyone had the same chiclet teeth smile veneers. Like everyone, they couldn't wait to smile, and their families haven't seen them in all this time. There's this big reveal. They haven't looked in the mirror in X number of weeks or months and that sort of stuff. And it was this thing. So you have a number of patients who would come in talking about, can you make my teeth look like the people on The Swan? Now this was the epitome of unrealistic expectations. Ma'am, you've been smoking 2 packs of cigarettes for the past 20 years, and you think all of a sudden I'm going to take your dirty, grungy brown teeth and give you chiclet white porcelain toilet bowl teeth and the smile that, you're going to get all the mans walking down the street. No, 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 no. Okay? So for me, an aspect of my seeking additional training in dentistry, more focused on itty bitties, was so that if I can impact their lives here, and we've got all of our prevention stuff in place, then, and we talk about don't smoke, so they're not 13, taking a hit for the first time, and now with legalized marijuana, that's a whole nother thing I got going, that's gonna end up coming its way, taking CE on all of that. Then we got all of our opioid stuff. So anyways, there's all these other outside influences that can affect the way that these children develop into adults and how they utilize oral health services. If I can do my part, and for my time that I'm acting as a clinician and dental educator, if I can be a part of training clinicians and treating my patients so that we could have a more positive influence on these youngsters as they grow into adult, then for those GPs years from now who are treating my used to be kids, hopefully you don't have folks who have developed these nasty habits, these deleterious habits, and are seeking your expertise and wanting them to have chiclet white porcelain bowl teeth and all these unrealistic expectations. All right?
Down the centuries, biologists have wondered why every face has this particular feature.
It's this bit here, the groove underneath your nose. It's called the philtrum. I've got quite a prominent one, his is less prominent, but we've all got one. What we now know is it is the place where the puzzle that is the human face finally all comes together.
We've taken data from scans of a developing embryo, so we are able to show you for the very first time how our faces don't just grow, but fit together like a puzzle. The 3 main sections of the puzzle meet in the middle of your top lip, creating the groove that is your philtrum.
This whole amazing process, the bits coming together to produce a recognizable human face, happens in the womb between 2 and 3 months. If it doesn't happen then, it never will.
Alright, so I thought that was pretty cool. It's like, where the eyes gonna be? Which ones? And who would have thought that the eyes were coming from over here to ultimately be where they finally are as the embryo develops. So that is just an aspect of when and hoping to keep it real can possibly go wrong. So in that first trimester is when all of that stuff is taking place. And like you said, if it doesn't happen then it never will. So the face is developing during that first trimester time frame, and that's where the maxilla and mandible are developing. And cleft lip and palate are fusion disorders that affect that mid-face skeleton. So that's what I was talking about, the skeletal thing. If that fusion does not take place in the mid-palatal suture, palate's two shelves. If they don't fuse here, then that cleft will forever remain until it's surgically repaired. And oftentimes cleft lip and palate, these sorts of mid-face disorders are detected in that first trimester ultrasound. There's multiple causes. Sometimes it can just be, it just happened. There's a familial aspect. So if you are a sibling of cleft lip and palate, then there's a greater chance that your child may very well be born with one. Teratogenic, so there's drugs, viruses, or chemical exposures, don't ask me which ones, that may play a role just when something is going wrong, when your body has to stop focusing on the developing fetus, the developing embryo, then that's where things can take place. And they could be part of a syndrome. So it takes a community. This is where a craniofacial fellow would certainly play a role in this aspect representing orthodontics. And a team, a craniofacial team usually consists of plastics and ENT, oral surgery, prosthodontics, or the pediatric dentist or general dentist, an orthodontist, speech pathology and audiology. Usually there's a medical nurse who's coordinating these sorts of things, a geneticist, because if it is part of a syndrome or if there's a familial tendency, it's helpful to inform folks where it's coming from so that people can plan their families in the future accordingly. Social work and a psychologist for these youngsters or the parents. A lot of folks might start to blame themselves. This is what I did, that sort of thing. Or a social worker to help connect families to resources. There are foundations that are out there to help assist folks financially, of course with an application, for certain aspects of their children's care. So this is after the surgery for this youngster. About age 1 is when that's taking place. So let's look at what Dr. David Satcher talked about in his Surgeon General's report on oral health in America that was published in 2000. He was talking about the oral health means much more than healthy teeth, and that oral health is certainly integral to general health, and that the safe and effective disease prevention measures, they exist so that people can adopt and improve oral health and try to steer away from oral disease that can have its systemic concerns as well, and vice versa. I think I went the wrong way. We talked about smoking, cessation, teen pregnancies, that aspect. Major findings that oral diseases and disorders in and of themselves affect health and well-being throughout life, that safe and effective measures exist to really try to halt the disease process in both tooth and gum health, and lifestyle behaviors such as tobacco use, alcohol use, I could easily add on here, other substance abuse issues, poor diet choices, and in utilizing oral and craniofacial services to help bring some of these aspects to life. A lot of folks don't know why things are, but when you start to make the connections, that light bulb goes off. There are profound and consequential oral health disparities that are found throughout the U.S. So this is a way that the Department of Health and Human Services tries to breach that, or tries to bridge that gap with programs that increase access to communities and people who have, who for that access are quite limited. But we're not there yet. There's still so many confounding factors that we have to consider when approaching this. So everything is quite dynamic. But it's ongoing. It's not like we're just, oh, well, we don't know what to do. It certainly is something that is constantly being looked at by all sorts of those sorts of specialties that we were looking at and listing earlier. So there is a research component to all of it to evaluate how we can constantly improve. We're truly trying to be more evidence-based in our profession and making decisions after assessing what research. Somebody's doing what? Who's compiling all of that stuff? What's out there so we can determine what are our best steps? What are our next steps? You'll hear people say that the mouth is the window to the rest of the body, and it's literally so. And we've talked about how the tooth is connected to a living, breathing, organ functioning individual. And so it's really important that you understand what you're doing and how it can affect their whole body. And at the same time, if someone presents to you with a medical history, you're already starting to think of what sorts of things may I see. One of the first things I say when I walk in the room and I have a new patient, I ask if they were a full-term baby or if there were any complications with delivery. I haven't assessed the child's oral condition. I've walked into the room. Maybe if we were walking together, I'm also looking and monitoring the way the child is walking. Are they walking on their tippy toes? Are they walking, is their gait normal? Do they have more of the sort of gait that might mimic, there might be some special needs associated, that this child might possess. When we're talking, I'm looking, is this child giving me eye contact? What's their interaction with their parent guardian? When I'm talking to parent guardian, I'm also looking at their teeth. Their teeth might help me get an idea of what I'm getting ready to see when I look in this child's mouth. All right? I'm usually sitting in my chair, maybe signing off on some paper, reviewing health history, but I'm also glimpsing at the child's profile. Am I going to see, is the jaw jutting out this way? Is the bottom jaw super in? Trying to get an idea of what sort of occlusion am I dealing with. With occlusion aspects, what am I looking at from a growth and development standpoint? Are we going to be able to catch up? Will there be enough space to accommodate permanent teeth? All of that stuff is part of my assessment, and I'm doing it in 20 seconds or less. All right? And yes, all research is ongoing. Alrighty? 10 minutes. Like I told you, I haven't had to give this presentation broken up. I'll just are y'all cool? We're good? Give me like 5 more minutes, and then we'll remember where we stop. Hopefully it's a good spot. So here's our caryology. Dental caries or cavities is caused by bacteria. And we have environmental, behavioral, and genetic aspects of dental disease and manifestations of decay. We have 2 primary culprits. 2, it's going to be your strep mutans and your lactobacilli. Caries transmission, you have, vertical and horizontal transmission. So vertical is from who to who? Or how is the relationship? Vertical? Mother and child, yes. So that's why I'm looking to see what mom's teeth look like. If mom or the primary caregiver has a mouth that is pristine, then I would like to think that they take really good care of themselves and they take good care of their child. If mom's mouth looks like she's been chewing on rocks for the past 10 years, then there's a really good chance that I might see something very similar in her child's teeth. Horizontal relationship is like who to who.
Brother or sister.
Siblings, classmates. It's fall. 'Tis the season for hand, foot, and mouth. Coxsackie virus is getting ready to get down for this season. Herp angina. All these kids they're now coming back, and they're going here, and I'm going to touch this toy, and here, and I'm going to put my fingers in your mouth, and I'm going to rub my eye, and I'm going to touch your sandwich. I mean, so it's just we expect all sorts of nastiness to be making its way into ERs and into our dental offices. Okay. Key components, that you have to have 4 things. You got to have the bug, you have to have the host, you have to have the food, and you have to have time. I made that myself. I was really excited. So we all know how the story goes. Bacteria consume fermentable carbohydrates. Their byproduct is mainly acid, lactic acid in particular. We know that the acid, the longer it sits on the tooth enamel, it's demineralizing. It's pulling out those key aspects of the tooth enamel and ultimately trying to burrow a hole. And that's how cavities form. Things like calcium and phosphate from our saliva aim to buffer that plaque acid and lead us back toward a process of remineralization. But this is how I just summarize that for my kitties. Got a cute happy tooth, yucky cavity bugs, junk foods, juices, and sodas in enough time because maybe they're only brushing in the morning. and they're going 23 hours and 58 minutes. That's if they brush for 2 minutes in the morning, with all of that stuff sitting on their teeth. So that's plenty of time for this process repeated, because if they forget the one time to brush their teeth, then now the stuff is sitting there for even longer, all right? And then we have an ouchie chew, all right? Just another depiction. Here's how I break it down, because kids aren't necessarily going to understand that. Kids know about going number 1 and number 2, right? So here's how Dr. Carey, the pediatric dentist, talks to kids. Ooh, do you like junk foods, juice, and sodas? Yeah. What's your favorite? Ooh, I like hot fries. And okay, do you like hot fries? When do you eat? Oh, I had it for breakfast. Or I'm picking out hot fries while I'm doing their cleaning, right? Because I can't do my assessment because now all of their grooves are red. I said, wow. Okay, well, you know that maybe they already have an existing cavity. You got a cavity bug in here, and do you know what cavity bugs like to eat? What do they like to eat? Hot fries, okay? So you are eating your hot fries. They're also eating your hot fries. And I said, but now when you eat your hot fries, how do you get rid of your hot fries? Ooh, I go number 2, right? And where do you go number 2? In the toilet. I said, and then you get to flush the toilet and it goes out of your life forever, right? Yeah. Okay, well, if a bacteria, if the cavity bugs live in your mouth, and they eat the same hot fries you eat, where do they go number 2 at? Oh, they boo-boo on my teeth. And yes, when they go boo-boo on your teeth, that's what causes holes in your teeth, and that's when you come back to me and everything's all ouchy. So are we going to go and have some hot fries? No, which I'm pretty sure Mom still has her leftover hot fries in her purse and is going to get about 10 minutes after they leave my office. But at least my dietary instructions and my oral hygiene, is all part of that. So if you don't want boo-boo on your teeth from the cavity bugs, then we have to make healthier choices for the kids. So in this circumstance, we see evidence of the demineralization that's taking place here. If it continues and cavitations form, so if we're not getting adequate salivary function and our diet doesn't change, and we're not doing the best at removing plaque from the teeth,